Good evening, people. Can you hear me? Good evening, Ashok Kumar, Abhishek, Harsha. Can you hear me? Am I audible to you? Thank you, Manika Agarwal. Shall we start? If you're ready, please put a thumbs up. We'll start immediately. Good evening, Manika Agarwal, Hariharan, Lahari, Vikas, Shreya Reddy, Harish Rahul, Vikas Awal. Hello all of you. Thank you very much for joining me right now. So, it's a long time since I have met you on YouTube, and I'm really happy to see you here on YouTube. And this is an open access space where anybody can actually try to learn something. In case of Unacademy apps, you need to have an app. Here, even without the app, you should be able to see the videos. Now, this topic is a multi-subject MCQ based topic on tuberculosis. When I say multi-subject topic, it does not mean it is pan-subject. I'm not trying to bring you to say that from anatomy till that of surgery I'll be doing it, because we did such kind of classes in the Unacademy sessions. We did for system-wise, lungs, liver, bone, or etc. etc. Here, we are doing tuberculosis in subjects where tuberculosis matters. So this will be more important for second year, third year and final year students to understand the clinical subject which is related to tuberculosis. Why tuberculosis? Because you understand India is a leading country in case of tuberculosis load, and sub-Saharan Africa and Indian load is the biggest in the world. And tuberculosis and diabetes are two important diseases plaguing India, and these two diseases can attack every inch of your body so that all systems can be involved. So in order to understand that, we are focusing on certain MCQs which can help us understand tuberculosis better. Now, if at all the session works fine, and if you all can actually like this, then we can extend the session for one more session again, and we can do more in case of tuberculosis. So let's look at this part here. Before I enter into the topic and the questions per se, let's look at this. This is how you can actually approach me and contact me on Instagram. You can follow me on Unacademy here, and this is my FB page, and you can approach us for the full-time course, the subscribed course. This is Operation NEET PG 2021, where I'll be teaching microbiology, a T&D session. Here I'll be taking microbiology test and discussion session, and in the NEET PG 2022 batch, I'll be doing full-blown biochemistry classes. So I'll be teaching biochemistry classes from the bottom up. We'll be having 70 hours of learning biochemistry in and out of it. And you can actually subscribe to my classes by using the code Dr. ASM or Dr. ASM-YT for 10% discount and exclusive access to my classes. Hello all of you. Thank you very much for joining me. So let's go for the first question. What country was last in the world without TB infection? That is, when we spoke about TB infection coming into equation, which was the country who got it the last? Do you have an answer? Yes. Hello all of you. Yes, I would expect an answer. Is it A, B, C or D? Which one is it, people? This is a PSM based question. This has been asked in Gen Medicine. So FMG students also should be knowing the answers for this. NEET PG preparing people also should be knowing the answer for this. Remember, if they ask you, where was the last smallpox case reported? It was in Bangladesh. So though it may not be hardcore subject, these are important information you should be knowing to answer certain MCQs. It tells you that you are more responsible towards the course of medicine. Okay, let's see how many of you got the right answer. Okay, there are many people who have given me the answer as D. Some of them have given me the answer as A. It's a wonderful act here. Very well. So people thought Russia and then people thought New Guinea. Accepted. The right answer would be New Guinea. The right answer is New Guinea. Well played, the people. Yes, it has begun. Yes, Begum, look at this. It was starting in Northern Europe more than 500 years ago. The disease spread steadily across the continent but did not move into Russia. Remember, Russia was one of the last frontiers to be broken. But New Guinea is the last place left uninfected. The first infection or development of TB happened in the year 1940. Remember, tuberculosis has been in vogue for more than 10,000 years. but reported cases started only 500 years back in Northern Europe, and the whole of Europe had a spread. And until the 1800s, Russia was not involved at all. The last country to be involved would be New Guinea. This is an important PSM question along with it a microbiology question. As I told you, it can be high yield question. It can be multi-subject approach. Hope you'll be able to use this information in the future. Welcome Raj Mohan, Krishna Mohan, Ramanan, Raju Ashni. Let's go for the next question. The average time of exposure to someone with active TB until acquisition of infection is about what? Is it 2 hours? Is it 2 days? Is it 2 weeks? It is 2 months. This may look like a very simple question or a silly question, but the truth is, when we go for the answers, we will not be exactly sure what to happen. Then we will try to understand how exactly pathogenesis unravels, because you have to know exactly the whole course of timeline if you are going to be sure about tuberculosis. Let me see how many of you can get me the right answer here. What is the right answer? Is it A, B, C or D? Which is the right answer for this question, people? So the most important key word here is average time of exposure. Let me tell you, if they ask you straightforward tough questions, it is easy to crack. That is, if you have a small ball which is very tough and people ask you to crush it, you can hold it, you can make extra efforts to crush it. But think about a very soft kind of plastic ball which is completely oily. When the ball comes into your hands and you want to crush it, the ball keeps on slipping out of your hands. You fail in the ultimate process of crushing it. The same logic can be applicable for these kind of questions. These kind of questions may look very easy and silly, but when you make a mistake, it will take away one question equivalent of marks. That is why I want you to focus on these kind of questions also. So I have received answers as B and C. All of you are wrong. The right answer is 2 months. The average time is what is important. It is 2 months. Please understand, the average time of exposure to someone with active TB until acquisition of infection is about 2 months. It means, generally when you compare tuberculosis with any other infection, for example, you have Staphylococcus aureus, you have Streptococcus pyogenes, you can have Corynebacterial diphtheria, measles, varicella zoster virus, etc. When you come across a person who is already suffering from that infection and diseases, when you come across him, if you get exposed to him once or twice, you'll be able to get the full-blown infection. Some other organisms may require more amount of time, for example 2 days. Some organisms may require 2 weeks, for example Legionella. Legionella exposure from the air-conditioned rooms, continuous recirculation of air can fetch you the organism. It may take 2 hours or even it can go up to 2 weeks. But when it comes to tuberculosis, you have to go for a minimum of 2 months, and that 2 months is the average. There are definitely reported cases who have acquired it within less than 2 months also. But average time of exposure is 2 months. This is what I want you to understand, people. Next question. Okay, look at the theory part here. Compared with other infectious diseases, TB is not easy to contract. Please understand this. Many people misunderstand TB to be highly contagious. TB is not highly contagious. What are the most important keywords? TB is moderately contagious. These are the keywords I wanted to know. TB is moderately contagious. It is highly infective. Infective means what? The ability of the organism to enter into the host cell is called as infection. It is highly infective. Also remember, it is less frequently pathogenic. Less frequently pathogenic. I may have 1,000 people exposed to the organism, but only 100 people can go towards tuberculosis. It is less frequently pathogenic, but it is seriously pathogenic. It is seriously pathogenic. In those people where the symptoms are starting, in those people it can be a deadly disease. These are the things I want you to consider before you choose an answer. Okay, now look at another PSM based question which can be general medicine also compared to that of microbiology. Look at this. Groups considered high risk for contracting tuberculosis who should be screened include HIV infected persons, injection drug abusers, and who else? The question is that among these 4 options, who else can be taken as a high group person who can contract tuberculosis and in whom I have to perform screening? I repeat, in the given 4 options, which option can be on the same plane as HIV infected people, injection drug abusers, so that they'll be considered as high risk group and they should be going for screening? Is it A, B, C or D? Which one is the right answer, people? Yes, I am getting answers as D, B, A. Come on, what are the answers do you have, people? D, okay. B, A, B, okay. So, is that all? Is that all? Okay. So there are quite a few number of people. That is, out of 20 people who have answered, 5 to 6 people have given the right answer. The right answer is emergency medical personnel. Remember, all hospital workers are not high risk patients. They are moderate risk patients. Persons with healthy immune systems are low risk patients. Why? Because when you have lower immune system, then the organism can proliferate very well. Please understand. Now, the immune system consideration is not based on the severity of the disease. Now, listen very carefully. The concept I'm going to tell you right now is slightly different from what you understand with respect to immune system. When you speak about immune system, the organism enters inside and destroys the human being. Understandable. It is a serious illness causing condition. But when the patient is having less immune system, then the organism is proliferating uncontrollably. When it is proliferating uncontrollably, the number of organisms are so high. For example, if it is lepromatous leprosy, it is multibacillary leprosy. In case of hematogenous TB, it is miliary TB causing state where the TB is floating in the blood. There is bacteremia because of TB. What is the importance here? TB bacillus is not supposed to be seen in blood. TB bacillus should be bound in the reticuloendothelial system or captured by macrophages, or they should be fighting the T4 cells. Rather than that, you won't find the organisms freely floating in the extracellular fluid called as blood. But if you see TB bacillus floating in the blood, it is purely because of low immune system. So persons with low immune system can be high risk patients. The best example can be HIV infected persons who are going towards AIDS. Also, injection drug abusers could have acquired HIV. Also, injection drug abusers can get the organism by injection abuse, but the most important high-risk people can be emergency medical personnel. Now, you might be slightly confused. How on earth will I be able to say whether it is the right answer? Because you thought A, B and C, D, the only thing that you could have ruled out would have been A, but you thought B and D would have been equally powerful answers for choosing, yes or no? You thought B and D can be easily chosen for consideration. But air pollution does not necessarily mean MTB. Air pollution can contain 100 ml of air being polluted by approximately 50 ml worth of pollutants. But out of the 50 ml, less than 1% can be because of MTB. You will have innumerable number of other bacteria and viruses, and chemical pollutants also can be seen. So air pollution need not be a high risk area. So what are the high risk areas? Look at this. HIV infected person, understood. Close contacts of people with active infectious TB matters. Please understand, if you are a close contact with people who have active and infectious TB, then you are a high risk person. Also, persons with low immune system, for example, chronic renal failure, diabetes, if at all you have gone for immunosuppressive therapy in case of transplantation, prolonged steroid abuse for anabolic properties, malnutrition, gastrectomy, all can be high risk areas. Why am I telling you this? They all can come under options for you. In the exams, they can come as responses. You will not be in a position to remember every single word by rote, but instead, you put them under a bigger umbrella. Tell yourself, any kind of disease capable of causing low immune status can actually be a high-risk patient, including injection drug abusers and residents and employees of, remember, long-term care facilities, prisons, mental institutions, homeless shelters, and group homes. These are high-risk people, but not all hospital patients. Only emergency medical personnel in the hospital can be high-risk group people. For the past month, the cough is now productive of several tablespoons of blood streak sputum. Look at this, the most important keyword. You're looking at productive sputum, and the sputum is revealing blood streaks. Also remember, this is non-foul smelling. The most important keyword is non-foul smelling. Tell me, if it is a non-foul smelling infection, then what can I rule out? What kind of bacteria can I rule out? Am I audible to you people? Can you see me? Please put a thumbs up if you can see me. Okay, so you can see me. So remember, anaerobic foul smelling is actually ruled out in this given question because there is no foul smell. So what kind of organism can we think of? We can think of facultative aerobes, facultative anaerobes, and obligate aerobes. So the one organism I can rule out would be definitely anaerobic infections. On physical examination, temperature is 30 degrees Celsius. It is not a high grade fever. Coarse rails can be seen on the apex of the lung. He has lost 10 pounds but says that he doesn't eat regularly. So, there is poor appetite and poor body weight gain. Culture of sputum shows no growth at 7 days, but buff colored colonies are visible at 21 days. Mark my words, 3 weeks. of the following organism, which one is the likely cause? The answer is Mycobacterium tuberculosis. I know all of you will know this, but why did I put this question? Because this is just a revision of how to see the organism in simple words. We are starting the question, right? So when we are trying to understand microbiology aspect of tuberculosis, these are all the features I wanted to know. Mostly homeless people can be affected more than the people who have proper shelter. And cough can be for the past 1 month, still the diagnosis may not be done. Remember, MTB is the most common cause in India for pyrexia of unknown origin. When is it called as pyrexia of unknown origin? Some people can ask me, you're telling me right now the origin of pyrexia is MTB, then how can it be unknown origin? Remember, if you want to define it, for 1 week of continuous investigations and culture, if you still cannot find out the organism, then you call it as pyrexia of unknown origin. For MTB, it will take more than 2 weeks for you to get the diagnosis. So it can be the most common cause of pyrexia of unknown origin. The next common cause can be brucella. Okay, and the cough is actually non-foul smelling, so it points towards aerobic property of MTB. And culture can be showing no results on 7 days, but on 21 days it can give me buff-colored colonies. And the most important part is apex of lung is affected. That indicates that it is attacking the most aerobic part of your body because the organism is a strict aerobe. Excellent, thank you very much. So the temperature is 30 degrees Celsius. The organism is not a typical organism. If it is a typical organism, then the organism could have produced pus. Pus producing organisms are called as pyogenic organisms, but this is an atypical bacteria, so there is no pus. When there is no pus, it means there is no dead neutrophils. When the dead neutrophils are not there, the neutrophilic membrane is not ruptured, so pyrogenic substances are not liberated. Pyrogenic substances can come out of dead membranes of neutrophils and RBCs. Because there is no neutrophilic death, there is no high-grade fever. That is why you can expect evening rise of temperature in this particular patient. Let's go for the actual question here. Look at this. Your patient is a 30-year-old woman who is infected with HIV and has a low CD4 count. She has HIV, low CD4 count, age is 30 years. She now has findings of pulmonary tuberculosis, but you are concerned that she may be infected with Mycobacterium avium intracellare. Regarding Mycobacterium avium intracellare, which of the following is most accurate? A. Disseminated disease caused by MAI is typically the result of decreased antibody production, whereas disseminated disease caused by MTB is because of reduced CMI immunity. I repeat, dissemination by MAI, that is Mycobacterium avium intracellare, is because of decreased antibody production, and dissemination of MTB is because of decreased CMI. Next, immigrants from Southeast Asia are more likely to be infected with MAI than with that of M. tuberculosis. C. MAI is typically susceptible to a drug regimen of isoniazid and rifampicin, whereas MTB is often resistant. Option D. The natural habitat of MAI is environment, whereas the natural habitat of M. tuberculosis is humans. Which is the right answer, people, among A, B, C, D? Yes, come on, tell me. What is the right answer here, people, among A, B, C, and D? Which is the right answer? Please be with us. In 10 minutes, the class will be over. It's a very short, crispy session. So try to learn as much as possible. And if you have any other special requirements from you for me to teach, any topics, you can put it in the comment box section. I will read the comments after the class is over. I'll try to pick up the best thing that can be useful for most of the students. I can teach you one more half-an-hour session like this. If you want more in tuberculosis, we can do tuberculosis also. Apart from tuberculosis, if you have any other recommendations that I can teach you here, please let me know. If you would like me to teach it, do it. Otherwise, it's not a problem at all. Okay, so now I can see a lot of people giving me answers as A. Some people have given me answers as B. But most common answer has been A, but the best answer is D. Please understand, the best answer is D, people. Why? Remember, what is wrong with all the other options? That is what you're supposed to focus on. Getting the right answer is not enough. Finding out why the wrong answers are wrong answers is even more your responsibility. Look at this. Disseminated disease caused by Mycobacterium avium intracellare is typically because of decreased antibody production, is what are they saying? Remember, be it avium intracellare or tuberculosis, all of them are mycobacteria. All of them are mycobacteria, and they will contain mycolic acid. This mycolic acid, along with that of cod factor, is well enough to prevent the neutrophils to come into the local area. Remember, the cod factor is also referred to as neutrophil migration inhibition factor, which inhibits the entry of neutrophils for fight. When neutrophils are not coming to the equation, then there will not be any kind of immediate antibody production. So remember, all mycobacteria are primarily dealt by macrophages, and when the macrophages fail, T4 and T8 immunity will deal with them. be it MAI or M tuberculosis, both of them are dealt by CMI. So MAI becoming more serious because of less antibody is a wrong statement. MAI is not dealt by HMI, it is dealt by CMI only. Now look at option B. Immigrants from Southeast Asia means what? This question is from the point of view of Americans or UK people. For us, Southeast Asia means what? Involving both India, Sri Lanka, Bangladesh, Japan, Bhutan, Nepal, all these areas along with that of Thailand, Indonesia. Those people will be more prone for MTB than that of MAI. Can you tell me what is the most common cause of tuberculosis in AIDS patients? Which mycobacteria is the most common cause of tuberculosis in AIDS patients? Yes, that is what I'm doing, Justin. These are the most important points I'm telling you. Is there anything else you would want? Okay, definitely I'll do it, Justin. Mineral metabolism applied, I'll do it. Yes, no problem. Okay, tell me, what is your answer? Manika Agarwal says MAC, Krishna Bhatt says TB. Any other answer, people? So let me give you multiple MCQs here. Listen very carefully. The most common cause of tuberculosis in AIDS patients in USA or Western countries is Mycobacterium avium intracellare or MAIC complex. But the most common cause of tuberculosis in AIDS patients in India is unbeatably the number one champion called as MTB. Nobody can beat MTB in India. MTB load in India is extremely high. Also remember, in both India and sub-Saharan Africa, the most common cause of tuberculosis in AIDS patients is also MTB. Because of the Indian load and sub-Saharan African load, the most common cause of tuberculosis in AIDS patients globally is also MTB. I hope I made my point here. Globally also, MTB is the most common cause. Remember, it is not MAC globally. It is not MAC in India. MAC only in case of Western countries and USA. But all over the world, it is because of MTB. In India and Southeast Asia also it's MTB. Okay, now let's focus on the option C here. Look at the option C here. They're telling you MAI is typically susceptible to a drug regimen of isoniazid and rifampicin, whereas MTB is often resistant. Of course, MTB is definitely resistant to INH, rifampicin. That is why most of the drugs can be multi-drug resistant tuberculosis. It can be extremely drug resistant tuberculosis. It can be TDR-TB, totally drug resistant tuberculosis. But if at all this MIC is taken into consideration, the MAI can also be resistant to isoniazid and rifampicin. They are not extra susceptible than that of MTB. Mark my words, option C is also wrong because MAI is typically resistant to isoniazid and rifampicin because it shares the similar properties of MTB. Then what kind of treatment can you give for multi-drug resistant MTB? And what is the treatment you give for MAI? The treatment for MAI can be REC. Remember, you can add rifampicin to that of ethambutol and that of clarithromycin. You have to add clarithromycin and ethambutol to rifampicin if you want to treat MAI. Isoniazid is not the primary drug that I can use in case of MAI. Excellent. Okay, thank you very much. Let's go for the next question. 20-year-old man with a single, slowly expanding, non-painful, scaly lesion on his chest for the past 2 months. Look at it. There is a single, slowly expanding, non-painful, scaly lesion. That is, if I use a blunt end of a scalpel, I can scratch it open, just like a fungal tinea infection. It is happening for the past 2 months on his chest. The lesion is non-pruritic. It means what? There is no itchy sensation on the lesion. This will differentiate the particular bacterial infection from that of fungal infection. The fungal infections will be less painful but more itchy. He has lost sensation at the site of the lesion. He is otherwise well. He is a recent immigrant from an endemic area for the given disease. An acid-fast stain of a scraping of the lesion is positive. Which of the following disease is he most likely to have? Cutaneous tuberculosis, fish tank granuloma, lepromatous leprosy, scrofula, tuberculoid leprosy. Which of them is the right answer here, people? Among A, B, C, D, E, which is the right answer? Come on, people, which is the right answer here? Excellent. So almost all of you have given me the right answer. It is E. What was the one single point that was in favor of tuberculoid leprosy? It was a single lesion. If it is a single lesion, is it multibacillary or paucibacillary? It has to be paucibacillary. Positive bacilli means the number of TB bacilli are lesser. When the TB bacilli are lesser, automatically the number of lesions also will be lesser. It is everything else can be a property of leprosy. Slowly expanding, non-painful, and it is non-pruritic. No pain, no itch. These two are properties of skin lesions caused in case of leprosy. This question should not have been asked when the topic was tuberculosis. But why did I add this? Because I wanted to sow the doubt. There was an element of doubt it could have been happened. So many of you have easily negotiated the question here. It was not in any way cutaneous tuberculosis. Why not? Because if it was cutaneous tuberculosis, it will not be causing anesthesia or hyposthesia. There was a loss of sensation, I told you, right? Loss of sensation can be a property of leprosy, but never a property of tuberculosis. That is the point that should have ruled you out of tuberculosis and ruled into leprosy. Next question. Which is the recentmost drug among the following drugs for the treatment of MDR tuberculosis? Is it bosentan? Is it bedaquiline? Is it levofloxacin? Or the fifth generation cephalosporin? For those people who do not know that there is a fifth generation, remember, we have heard about first, second, third and fourth generation of cephalosporin. Right now we have fifth generation also, which is ceftaroline. Ceftaroline is an example of a fifth generation cephalosporin. Take all the equations and tell me which is the right answer here. What is the latest drug that has been used for treatment of MDR tuberculosis? Excellent. Many of you are giving me the right answer. The right answer is bedaquiline. What exactly is wrong with levofloxacin? Levofloxacin is not the recentmost drug. It was used for the last 15 to 20 years. There is no doubt about it. Bosentan is not at all related to tuberculosis. What kind of drug is bosentan? Anybody? What kind of drug is bosentan? Anybody, people? Correct, Ashok Kumar. Ceftabiprole is also another example of fifth generation cephalosporin. Can you tell me what kind of drug is bosentan? It is an endothelial what? It can relax the endothelial area and can be helpful for pulmonary hypertension. Very well played. It is helpful for pulmonary hypertension. Okay, what kind of drug is bedaquiline? Bedaquiline has what mechanism? Can you tell me, anybody? No. Bosentan is not an AC inhibitor. It is an endothelial cell relaxer. Yes, it can be used in pulmonary hypertension. Yes, correct, Vivekananda. That's a good answer. Bedaquiline. Can you tell me what is the mechanism of bedaquiline? Yes, Bignesh and Ilasish are giving me the right answer. So that you are very close but not exactly correct. There is a concept called as, no. It is not ATP. It is ATP synthase inhibitor. ATP synthase inhibitor. What does this tell you? If I have ATP synthase, which complex is this, people, in electron transport chain? Remember, it is not an ATPase, it is ATP synthase. Please understand this difference, Hemant Singh. It is not ATPase inhibitor, it is ATP synthase inhibitor. Remember, you have electron transport chain inside the mitochondria. In mitochondria of eukaryotes, we have electron transport chain. We have the electron transport chain present in the inner membrane and intermembrane space combined together. We have complex 1, complex 2, complex 3, complex 4. The flow of electrons is from 1 to 3 to 4 or from 2 to 3 to 4. Now the fifth complex is referred to as ATP synthase complex. Why am I speaking about the electron transport chain in a bacteria? Remember, MTB is the gold standard aerobic bacteria. Aerobic bacteria means it depends on oxygen and it uses oxygen. Two important points. One is it depends on oxygen for survival. On the second point, it not only depends, it also utilizes oxygen for survival. It undergoes oxidative phosphorylation. Oxidative phosphorylation happens in the aerobic bacteria. So bacterial aerobic ion-based metabolism will have to happen. Cytochrome metabolism will happen. In that, ATP synthase complex can be inhibited by bedaquiline, and when the ATP synthase complex is inhibited, even though MTB is highly aerobic, even though it is staying in the apex of the lung, it will be deprived of the ATP, because of which organism becomes weaker and dies a very slow death. This is why the bedaquiline can be effective in multi-drug resistant tuberculosis. I hope you'll be able to remember this. Next question. Fast acetylators of isoniazid are more prone to develop what? A, B, C, D. Which one is it? Fast acetylators of isoniazid are more prone to develop what? Among A, B, C, D, which one is the right answer? Come on, people. Okay, so there are equal number of there are equal number of pupils or students telling us that B and C are right answers. Very rare people are saying A. Okay, now let me end the discussion here. Look at this. What do you mean by fast acyclators? This speaks about the individual, the human being, individual who can add acetyl group to isoniazid. That is, if at all this individual is called as slow acetylators. If the individual is called as a slow acetylator, then conversion of the native drug called as isoniazid or INH, let me write it as INH, the native drug INH has to go for a step called as acetyl INH. Next, it has to go for one more step. Can you tell me what is the next step, people? For those people who gave me answer as C, do you know that when I have native INH, the first step is adding acetyl group to it. When acetyl-CoA comes inside, CoA is removed, acetyl group is attached to INH. This is called as acetylation step. This is called as acetylation step. Very good, Vivekananda, I understand, but tell me, there is not the right answer. Tell me, after acetylation, what happens? Anybody? After acetylation, what happens, people? Okay, so you might not have come across this many times. So let me tell you this here. When acetyl NaOH happens, there is one more step. No, not catalase and peroxidase. Okay, let me give you this as a homework for you. I'll tell you this. Take this as a homework. I'll give you the remaining answers. Just find out. No, it is not getting excreted. Yeah, Faiz and Siddharth, it is not getting excreted or it is becoming catalase peroxidase. No, acetyl INH can become X-INH. Find out what is X. Okay, just as a homework because it can stimulate your thought process and you can use it better. Let me explain acetylation here. Now there are people who are called as slow acetylators. There are people who can be called as fast acetylators. What is the difference? If at all they are slow acetylators, most of the drug INH will tend to remain as INH itself. 90% of drugs will remain as INH. The native INH is extremely toxic because INH can inhibit an enzyme called as pyridoxal kinase. If the people are slow acetylators, acetylation is not happening, so INH will remain as INH itself. So that INH can easily inhibit the enzyme called as pyridoxal kinase. Pyridoxal kinase is important for converting normal pyridoxal into pyridoxal phosphate. What is the importance of pyridoxal phosphate? The active form of vitamin B6 pyridoxine is pyridoxal phosphate. Only when pyridoxine becomes pyridoxal phosphate, it can be helpful in biochemical reactions. What is the function of pyridoxal phosphate? Let me erase all the annotations here for you. Please remember, this is a combination of pharmacology, microbiology and biochemistry. Please be with me. If I have the enzyme called as pyridoxal kinase, not pyruvate kinase, pyridoxal kinase, I will be able to convert pyridoxine or pyridoxal into pyridoxal phosphate. Now this kinase is inhibited by the drug called as INH, the native drug. So PLP is not available. PLP is important for what kind of activity? It is important for decarboxylation. Decarboxylation is important in amino acid metabolism. For example, glutamate on decarboxylation can become gamma amino butyric acid, referred to as GABA. So it means if PLP is not happening because of PLP kinase being inhibited, so GABA will not be synthesized, which can lead to peripheral neuropathy. So remember, slow acetylators are the people who will not be able to convert INH into acetyl INH. If acetyl INH is formed, it is not toxic. Please understand, acetyl INH is not toxic. It can perform its antimicrobacterial action and can be excreted. But when the slow acetylators are present, then INH remains as INH, because of which there is peripheral neuropathy. Now, there are some people who are called as fast acetylators. Those will actually immediately convert INH into acetyl INH, but acetyl INH will become X-INH, which you are going to find out. You people go and find out that X-INH can happen rapid fast. So when they are slow, it remains as INH. If they are fast, it becomes X-INH. Find out what is that X. That X is hepatotoxic. So conclusion is that if a person is capable of going for fast acetylation, he will convert the INH into acetyl INH, also converts acetyl INH into X-INH. That X-INH is hepatotoxic. So in the question here, hepatotoxicity is the answer. I hope you understood this. If you didn't understand, please let me know. I'll explain it to you again. Excellent, Vivekananda. Very good. You're looking at hydrazine. INH will become hydrazine INH. Very good, Vivekananda. You did not take any amount of time. You did not go for homework. You gave the answer. Very well played. Remember, yes, Neharajan, isonicotinic acid is the right name for the isoniazid. But I'm telling you, this is the equation of steps. So there was no necessity for a homework. Vivek has given us the answer. Let me tell you this faster. What we are giving is INH. What it should become is acetyl INH. If at all he is a slow person, then acetyl INH is not found. INH is more in case of slow. If he is fast, he will instantly cause acetyl INH and then he'll convert acetyl INH into INH with a hydrazine. This INH with a hydrazine is hepatotoxic. If he is a fast person, INH is becoming lesser, acetyl INH become lesser, but INH hydrazine is increasing, which can attack your liver. That is why hepatotoxicity is the right answer. Yes, failure of therapy is possible for both. Remember, for both slow and fast acetylators, failure of therapy is the most common symptom and most common difficulty, along with that of peripheral neuropathy and hepatotoxicity. Do you know what are the drugs which can go for slow acetylation? Which drugs can be affected by slow acetylation? It is referred to as SHIP. S stands for sulfur drugs. H stands for what? Hydrazine. I stands for what? P stands for procainamide. What does I stand for? INH. Excellent, Vivekananda. X is acetyl hydrazine or hydrazine INH. Okay. So, no, Justin. X is not resistant. X is hydrazine. Yes, SHIP full form. You know it. You know it better because you know mnemonics very well. So, with this, I conclude our today's session. It was a very short session. I hope I have given you enough amount of information which can be helpful for you. And if you wish to follow me, you can follow me on Instagram by searching for Win Emperor. You can follow me on Unacademy by searching for Meenakshi Sundaram AS. If you follow, the updates will be coming onto your app. And you can ask me questions on FB page also. If you wish to subscribe for the Plus courses, which are starting right now, 6 months hard courses, you can use the referral code as Dr. ASM and Dr. ASM YT. And for being very patient audience, thank you very much. And if you need any other classes, please put it in the comment box section. When I read them later, I'll take your comments. I'll actually take your recommendations and put forward new fresh classes. Thank you so much. Have a good night. Bye-bye. Happy weekend, people.